Thank you all for joining us. I know this conference is always about choices and where you go, and we appreciate that you're here. My name is Cynthia Grant. I'm a licensed clinical social worker. I've been in the behavioral health field for quite some time, and I work for Grow Therapy. Grow Therapy is one of the sponsors of BHT, an organization that really prides itself on quality in terms of the services that are delivered by our therapists and psychiatric practitioners and measurement-informed care. So we are here today to talk specifically about how measurement-informed care needs adoption from stakeholders in order to be effective. And so this is a topic that we have an amazing panel of people who I've personally had the chance to interact with over the years, in that they are all true champions about measurement-informed care. We've got a nice diverse group, and I'm going to let each person introduce themselves briefly, and then we'll get going. Liz?
I'll start. Hi, good afternoon, everyone. My name is Liz Jones. I'm a licensed mental health counselor. I work at Lucid. I have the privilege of leading our clinical strategy, our quality department, and our clinical research team, and so have had the opportunity to partner with some other folks in terms of our measurement-based care tools, platforms, and then how we're leveraging that with our partners. We serve over 15 million members across the United States. So.
Hi, everybody. I'm Ann O'Grady. I'm Director of Behavioral Health at Independence Blue Cross. I'm a licensed clinical social worker, and the majority of my work has been focused on access to quality care and strategies around access to quality care and value-based payment and provider partnerships.
Good afternoon. My name is Paul Geiger. I'm a psychiatrist. I'm currently in the role as medical director for behavioral health at Providence Health Plan, which is a regional health plan mostly in Oregon. I've been with the Providence organization for 20 years, and my prior role, I oversaw the Oregon medical group for mental health, and right now I oversee the kind of the mental health program in our regional health plan.
Good afternoon. Doug Henry. I'm a clinical psychologist by training and background, and serve as the VP, and I'm just trying to remember, medical director of enterprise behavioral health for Highmark Health. And my background includes everything from private practice work, inpatient locked psychiatric units, SUDS detox, to building ambulatory systems for counties, metropolitan areas, and now for health plans. And at Highmark, the task is for about 7.5 billion members to build the most effective and highest quality behavioral health service. And those are my personal missions as well, to provide broader access to higher quality care that makes a difference for people.
Thanks, everyone. So before we get going, I want to call attention to the QR code up here. I don't feel like some of the sessions have made this as clear, but I have an iPad. If you type in your question, we can interrupt the panel and answer that specific question. This is a very engaged group, and we're really interested in having a conversation as much as possible, so please feel free to submit a question if something comes up even as we're talking. So one of the first things that we really want to talk about is, why is provider buy-in so important for measurement-informed care? And each of the panelists has sort of a different perspective on that from here. And so I'm actually going to start, and we're going to go this way first. So I'm going to ask Doug, I'm going to ask you to go first. Why is provider buy-in so pivotal to measurement-informed care?
Well, because you won't get it without it. So let's start there. And we know that buy-in is hard, right? People have their ways of doing things, and we as human beings don't like to change. And a lot of times to providers, and having been on that side of the fence most of my career, I sympathize, to do all of this administrivia that it feels quality distant and not as meaningful for the patient care as they would like. And so the fact that they've got to get treatment plans signed, and was this signature within the right date frame, or all of this sometimes feels like it gets in the way of treatment as opposed to securing quality. So you have to demonstrate to the providers that this has to do with quality. This will improve your patient care, and you have to sell that effectively or they won't do it. And there's plenty of papers and tons of evidence showing that measurement-based care, people get better more quickly if you provide it.
Well, great answer. Maybe I'll crib a little bit from that. I think that obviously you need buy-in from the providers. I think also, there's a participation on the patient level too. So if the provider is not bought in, you're not going to get the patient participation to get accurate data or maybe any data. So I think that's important. And the buzzword these days is value. We talk about right now as a payer, we pay for visits, not outcomes. And I think that payers, society, our clients who have entrusted us as a fiduciary with the dollar want to see outcomes, and they just they don't want a widget anymore. So I think that that's really important. I think providers are seeing that. I think interestingly, this space, this tech space, is really going to be transformative because most of the tech companies providing care are doing measurement, and they're kind of setting that as table stakes. And I think, if I look at our market, Portland's probably the biggest part of our market, more than half of the visits are done in kind of onesie, twosie solo practices that aren't really measuring or have the capability to do measuring. And they're going to have to adapt because, the other players that are gaining market share are measuring, and that's going to be the new kind of basic standard. So I see that kind of rising the tide all along. So I think it's, they need to have buy-in because they're going to get left behind if they don't do it, I think. So I think that would be my take on it.
I think just kind of coming from the clinical perspective, I think most providers want their patients to get better. So that's, to me, the best hook when you're talking with providers. Do you want 75% kind of improvement in remission versus treatment as usual without measurement-based care? I mean, that's one of the most, I think, important data points that came out of, I think, the Fortney paper, kind of the AIMS research. So do you want people that get better, or do you want kind of to continue or, stay kind of in a place where you don't really know whether they're getting better? So I think that's, to me, just the biggest hook kind of for a provider.
Similar perspective, a little bit of a different take. I do think that one of the things that we're struggling with as we're gaining more and more adoption of measurement-informed care is that measurement-informed care takes on a new meaning that's more relevant to the data that we're getting from measurement-informed care. And I think globally we need to continue to have the conversation that measurement-informed care is the act of engaging in that collaborative relationship with the patient, which is what informs the treatment outcomes. And if you don't have that collaborative engagement, if you don't have that model, if the measurement is not informing the care, then you're not going to drive those quality outcomes. And so I think we talk a lot about moving to measurement-informed care as a way to demonstrate value and demonstrate quality, and we have to pair that with how are providers engaging with patients relative to this measurement, right? Are they actually having those conversations? And when you look at provider perception across the literature, a lot of providers are still struggling with, well, this is for the payer, or this is for my administration at my organization, and this isn't for the patient. And you have to get that buy-in of, when patient experience is evaluated, patients have a wonderful experience with measurement-informed care if it's teed up correctly, if it's discussed as something that this will help me gauge how you're moving along your care journey, and it will help us see, versus this is an assessment that you have to fill out because it's some contract I have with a health insurance company, right? And so I really think that provider buy-in, when we're looking at sort of systemic change and integration, we have to be looking at fundamentally, do we have the infrastructure to support the clinicians who want their patients to do better, knowing that this is kind of what's going to help drive that, and this is a tool rather than an administrative requirement or burden.
These are such good answers. And I think that one of the comments about it being really foundational, that this is table stakes. This is not something that a provider really is going to be able to win with the pushback. But I'm curious, we do see that there are different levels of adoption. There are some barriers, and you heard some folks mention this. And so what are some of the differences that you all are seeing in terms of implementation of measurement informed care? And I think when we did some prep work for this panel, Anne, you had some thoughts about some of the differences in adoption from different providers. Would love to hear your thoughts.
Yeah, it really varies kind of as much as the patient population varies. I would say the provider community is really in different places. And I do agree that those that are using platforms or digital, that are technology sort of focused, really are more advanced. But we're even seeing some that have been around for a while with technology and are really starting, just initiating kind of their program. So I think we need to allow for that. I think the question really is kind of how serious are providers about it, and how are they planning to really kind of roll it out and to implement it, and then really how do they sustain it, and how do they promote it kind of within their provider population. So at IVX we have an outpatient professional incentive P4P incentive program that doesn't contemplate clinical outcome measures. It's really a V1 or a starter model to try to prime providers to really be looking at data. It's based on claims-based measurement. But I think we are really hoping that kind of beginning the dialogue kind of around kind of those types of starter models is a way to start to bring providers kind of into the fold and have the discussions just around measurement, whether they're clinical outcomes or claims-based measurement, to really kind of start to move the needle. So I think there's the digital sort of provider group, and there's the traditional provider group. Many of them are the solos or single shingles who are not using kind of EHRs. And I think we really do need to do more for them. So just a little bit of my thoughts.
Anyone else want to comment about barriers, slow adopters?
So I completely agree with everything that Anne is saying in terms of there are so many innovative tech organizations who are out there who are building platforms, who are doing it themselves. And then there was great discussion this morning on the panel about, well, that's not the majority of a provider panel, right? And so, how do we continue to support our communities where we have providers who are single shingles, who don't have administrative staff, who can't afford EHRs? And so I think it's really important when we're looking at barriers to acknowledge sort of implementation costs and tech costs. And so one of the ways that, and I do think we have a responsibility as payers to support that, and one of the ways that we've done that is sort of that varying value proposition and varying support across different levels, right? So where we have partners, provider partners who have the capacity to do API integrations via their EHR, we're doing that. Or we have provider groups who are saying, are you kidding? I can't even hire an administration at the front desk. We're saying, we'll use our platform. Here's a login. You can use it. You can leverage it for your patient caseload. We'll give you those insights. So I do think that we have a responsibility and an obligation to the single shingle and the smaller providers who are out there in the ether at varying stages of adoptions, and saying, okay, how as a larger organization can we support this and enable this and provide some infrastructure for your patient caseload so that you can continue to move the needle forward.
Yeah, and I'm going to answer this one too. And there's a question that came in that actually taps right into this in regard to how do you enhance provider knowledge and develop tech to support their practices. So thank you, Anonymous. you know, Grow Therapy is both a platform and a national behavioral health provider that gathers many people that are single shingles and gives them all of the tools that they need. The Lucette product, you know, there are these opportunities to be able to tap into it. And when providers connect with a group like us, we're doing a lot of the lifting for them. And so the amount of work, the administrative burden that they have to do, we remove all of that for them. And so I think that there are absolutely solutions that are out there, and part of why it was really important for us to have different perspectives on this panel, both from payer and provider, is because it really is about this partnership that we're working together to be able to raise the tide for all providers to be able to move this way. So I hope that that answered part of the question that we're looking at. Did you have something, Paul, you wanted to say something too?
I mean, I guess I'd categorize this under a barrier. I don't know that we've landed on what should we measure and how should we interpret what we're seeing in terms of change. I mean, I think, you know, at the extremes, I don't think anybody would doubt, for example, a patient with a PHQ of 24 who enters treatment and goes to 6, that's probably not a success. But, you know, what does 14 to 11 mean? What is meaningful? And PHQ is PHQ. That's just one thing, and it's not a diagnostic tool, right? It's a screening tool. And are there other things? And so I think that we still have yet to develop kind of the best model of what we should be measuring necessarily. There are these kind of interesting, you know, patient-reported outcome adaptive surveys that kind of respond to the, you know, what the questions are, focusing on functioning. So I think that's a barrier that, like from a science standpoint, we're not settled on what to measure and what's meaningful. And there's a little bit, I'd say, the final barrier is a little bit of a strain in the provider network about some of what we do is not measurable. You know, people who are, you know, existential problems or life crisis, and you can't measure what we do. You know, the analytic community has said that forever, right? You can't measure us. So I think that the science needs to kind of catch up. I think we're still waiting for 3.0 about kind of what the best practices around that.
May I?
Go for it.
Thank you. So I want to take a little bit of a different position on that. I do believe that we have to grow up, but I don't see excuses for anyone who is providing psychotherapy or psychiatric services not to be providing measurement-based care. Even if you are a solo private practitioner that provides services for free and has no money, okay? To engage in measurement-based care, you know, is not the same thing as having an EHR that automatically aggregates your data and tells you your average PHQ-9 difference. There are many ways to measure care, including some things on pen and paper that are very quick that work just fine, okay? So I think that the provider community needs to grow up and quit hiding behind the you know, intersubjectivity of mental health is such that, you know, we can't, it's not equal, you can't measure this, you can't measure that. And I get what people mean, but to hide behind the fact that every mental health situation and scenario and human being with a mental health challenge is idiosyncratic, the same is true of all of medicine. Every leukemia is idiosyncratic too. So if we, as people interested in mental health, want to be treated on par with other subspecialties, we need to grow up. And of course you need to measure the progress. You need to be able to point out to the patient, hey, you know, who's been seeing you maybe for months, and hey, look at where you were when you came in. You know, I know it feels like it's slow going, but you're 7 points different on this scale. Like, that is a significant improvement. It's very reinforcing for the therapy. So I want to kind of separate the notion of providing some form of measurement-based care with things that are actually more complicated, like developing systems of value-based reimbursement based on measurement-based care. And I want to mention another barrier, and you just mentioned this, Paul, and that is that the lack of universal tests or screens and agreement about what to measure. If you are a psychotherapist and you've been treating people with depression for 20 plus years, someone presents with a historical diagnosis of major depressive disorder recurrent and says, I would like to engage in psychotherapy for treatment of my depression. You don't want to administer a PHQ-9. That's like not a precise enough tool. That's like a screening tool for primary care. Okay, it's not what an experienced psychologist would use. You want to do a Beck depression inventory or something very, very specific that is going to give you some insight into the nuance of this particular depression. So the fact that OCD has one set of scales, anxiety has another set of scales, PTSD another set of scales, yes, that has to be taken into consideration. And the situation of those single shingle providers needs to be at the forefront of our thinking, but we need to not shy away from measurement-based care or hide from it at all or tolerate such.
Well, I'd say you can do both, right? So there is value for having universal measures that can be used across payers, across clients, and then having the more diagnostically specific. There's a lot of benefit. There's a number of questions that are coming in about how providers don't learn about how to use measurement-informed care. And Doug, you and I am very deliberate in calling it measurement-informed care. The National Council for Wellbeing came out with a white paper about the difference between the two. And I've had some really good conversations about that. This is just one decision tool in your clinical toolbox. It is not the end-all, be-all. And so I think to your point, we also have to get over some of the stigma that providers have. Oh, that doesn't apply for my situation or something like that. So this is a very common, there's probably like 4 questions here about specific techniques and education that people use to be able to get provider buy-in. So does anyone have any strategies that are worth mentioning in terms of how you get providers to be able to overcome using measures in their practice?
I'll go.
I would think Lucette might have some ideas.
So I think it's a couple of approaches. One, I think it's very relevant that there are multiple questions about providers not being trained to use measurement-based care tools. And so I think a mandate without an offer for support, right? I do think, Doug, that there's a need to mandate providers to be using measurement-informed care, right? We need it. Members need it, patients need it. If we're ever going to move to kind of V1, V2, V3 of value-based payment arrangements, we just have to get there. But we have to also support providers, right? I mean, we know we have provider shortage. We know we have access challenges. We know we have a young workforce, right, who needs support, needs additional education, and we have an opportunity to do that. And so we do have sort of a Lucid University with training and education about the benefits of measurement-informed care, and then also training and support on how to use our tools, and that's paired with an enablement team that is supporting providers who have inquiries as they come up. We use sort of behavioral analytics to engage and pull providers about questions that they may have, support they may need. So that's sort of one foundational pillar. I think the other is making it easy, right? Making very simple things like using UI to kind of color code. This went up, this went down, right? And I know those seem very simple and like we're just kind of spoon feeding, but when you are a clinician seeing patients back to back to back every, throughout the day and stacking them, you need tools that give you quick, clear insights into your patient's progress over time, right? And how that journey has changed. So that can range from, red, bad, green, good, right, to we have some HLM modeling that develops an expected treatment response. So you can see, okay, I'm seeing Susie today. Patients like Susie with these clinical factors typically progress this way through treatment. Is Susie on track, off track? What does that tell me? How does that inform the conversations that I'm going to have with Susie? as a clinician. And so I think that that can really help in terms of getting engagement, supporting late adopters, right, and mitigating some of those barriers.
I think I agree with Liz that providing support and tools really is kind of a critical for payers. It is challenging, though. Most providers, especially the traditional providers, solos or small groups, singles, are working with multiple payers. So to kind of require them to sign up with your specific platform kind of while knowing that we're 30% of their panel is, I think, a significant issue that we can't ignore. So I think it's challenging. I think the other way that we've been successful is really identifying providers in the network who are champions and connecting those that are kind of on the sidelines or sort of, not really there with peers, and kind of doing that connection and allowing those conversations to take place. I'm not really big on sort of the scare tactics and sort of the, well, if you don't do it, you're gonna be left behind. I think providers know that they have to make those decisions. I generally just sort of stay away from that. I'm not a big fan of kind of saying, you better do it for the payers so that the payers are happy. Because I think that just doesn't engender kind of really the right sort of spirit of as we've all said here today, it really is a practice. It's part of your fundamental belief about how you deliver care, and to do it sort of because somebody's telling you need to do it or you're going to be left behind just isn't, to me, really going to amount to a whole lot of productive sort of work. So, I mean, that generally is how we're approaching it. We have a number of what I would call champions, and they represent various different kind of groups within the provider network, and they're out there really willing to talk to provider leaders, group leaders, individual practitioners, just around how they've approached measurement-based care and what the processes look like and why to do it or why not to do it. So that's us.
Part of I think what is going to help is, and I don't know that we're here yet, but I think, so this is not something that we're doing, but I think having a story that is digestible and believable will help. Because right now, like I said, there's just too much heterogeneity around, well, I'll measure, but how is it going to be interpreted? How am I going to be judged? That doesn't feel scientific or accurate, and there's not agreement on this. And, I'm on these AHIP calls, and there's debate about what should we do. Is it a 5-point change? Is it response? Is it remission? Recently, they had a presentation. I think there was someone from the CDC advocating for, instead of looking at a delta, why don't we just have thresholds as a measurement? So it'd be people who are kind of under moderate or under mild, and have that be the goal, or bands. So I feel like, we don't have our act together necessarily, knowing what is it that we're really going to hold people to. I think that conversation is maturing. And I think once that does, in a convincing way, that's going to be very helpful to get providers to come along. Because right now the story is a little, if I was a provider thinking, well, you're going to measure me, I don't know if I believe that this is going to work, or you're going to capture my work here just because of the tools are insufficient. So I think that's coming and necessary.
I know we have providers in the room, but the CDC, we're not sure what we're doing. We don't know how to measure is certainly not breeding confidence in the tools. And especially if we're looking at providers to be the ones to be able to educate their clients to be able to do this as well, we definitely have a hurdle. One of the things that I think we do need to talk about that as a non-payer, I have asked all of them, is what do you do with the data? And this is something that I feel like providers don't have a good understanding on, and I think clients may have mixed views, but when we talk about, to Ann's point of we don't want to tell a provider, oh, just do this because it's in your contract. Oh, it's a requirement by the payer. Some of the resistance we know is, how do you use the data? And so curious minds want to know.
Well, I'll just respond just to the point that was just made. I haven't been on the AHIP calls, but at IBX we're really clear about what we're looking for. Response is 50% improvement, and remission is no longer meeting DSM criteria, kind of no functional kind of impairment and back to functionality, and then looking at the criteria for how long, for depression, it's usually 8 weeks sort of that you maintain that. So that's really what we're shooting for, and we're really looking at bringing in the data and kind of learning from it. Ultimately, where we want to be is to understand the providers that are getting to remission and moving more members to those providers that get patients to remission. That's the gold standard. Even with response, you have recurrence. So while response is a great result, remission really is the goal. And so that's really what we want to do. We're in the sort of kind of the path of bringing in data ourselves, working with a curated sort of set of providers, looking out at kind of what tools and tech we're going to bring to the provider network overall, and really not focused on one provider, but working with anybody that is willing to sign an amendment to provide us with clinical outcomes and meet with us regularly to review those results and kind of engage in kind of a joint kind of collaboration approach.
So at Lucid, we're using it to answer the question, what does good look like? And then how do we help facilitate patients into providers who can support their clinical presentation and profile, right? And so that's like a whole lot of, mumbo jumbo speak for basically, we're using it as an aggregate level, right? And I know that we hear a lot from provider space and just kind of out there in the ether in terms of members and concern about data and privacy and security. But it's really used at the aggregate level to say, okay, what can we look at in terms of benchmarking, tiering, what is good, right? There's a lack of consensus, but payers are beginning to get this data, right? We're using APIs to get integrations where folks aren't using our platform, they're using theirs, right? How can we get that data and then use it as an aggregate level to say, okay, you're doing really well, you are achieving remission. How do we stack contracts to look at sort of benchmarks or tiers to hit in terms of clinically significant change, remission, response, right? And how do we do that with some kind of overall distress measure that does look at functional improvement as well beyond sort of just I know we talk so much about PHQ-9 and GAD-7, and I feel like that's all of the conversations are all centered around, and even we're in arguments about sort of, what's the best threshold for PHQ-9, which is the only one we talk about, right? And so I think it's using that data to drive decision-making, contracting decisions, and then just on the front end, steering in terms of how do we match the right member to the right provider. Obviously, steerage is limited for any payer, but where we're able to, we do have modeling to help kind of drive into providers who have demonstrated results with patients like them. So I know that there is a lot of concern about, is it being used for utilization management and that, and I think we've all moved on from that, right? I think the name of the game is access. However long ago we were looking at outpatient utilization management, I think parity has shifted that conversation greatly. I think just general shortages and access needs and challenges and the need and the demand for behavioral health has really outpaced that conversation about leveraging data to somehow reduce utilization. So that's just kind of like one perspective of pushing back against that perception that that's how it's being used or why it's being used, because it's not. It's being used to kind of steer into good outcomes and quality care.
This needs to be one of our banners, right? In terms of, and I wonder, you talk about the behavioral health field changing and from utilization to access. We're talking about parity. We're talking a lot about measurement-informed care. Measurement-informed care is definitely something that we talk about, and yet there are still concerns, and with data breaches and privacy, there are definitely issues that have emerged in the field. So I think we're on to something. We have about 10 more minutes, and I am getting some questions about different subpopulations. And so folks in the room, there's a couple that have asked specifically about pediatrics or about working with measures with children, special populations, how to make it meaningful for the provider. Some of these are comments as opposed to questions. Anything you all would want to talk about in regard to especially measures with kiddos, which I think are a very complex situation given parental involvement?
I'll take a stab at that. First off, we have to make room for all of the different types of measurement-informed care that pediatric providers may need to engage and may need to provide. So again, you cannot say PHQ-9, GAD-7, that's what we want, don't talk to me about anything else. What a disaster that would be. We can do much better. So if you have a child who's experienced an adverse event, you're going to apply a TESI. If you got a kid that looks like it might be OCD, you're going to use a Y-box or similar. So we have to, as payers, not try to jam every provider into the same little box. And I think that I'm hearing that theme over and over again in some of the responses, and I like it a lot. That's the truth, because kids are different. Kids are less amenable to video treatment, at least under age 10, and special in lots and lots of ways. That is not, I am not saying you can't measure it. You can measure kids in the same ways, not using the same tests, but in the same manner that you measure adults. And it needs always to be measurement-informed care so that you can change things up if you're not making progress, right? And as far as how do we use the data, we use the data to try to make the care better, to raise the quality of care, and to feed that data back to the network providers so they themselves can see what their strengths and vulnerabilities are. And also so that we can see, geez, we don't make much progress. Our network doesn't do very well with eating disorders, compared to depression. So we need to use that information to make things better, to make the services better. Now, I'm saying that. I have a counterpart at Highmark Health who I'm sure would say, we're trying to suppress TCOC. It's the exact same thing. I mean, our business strategy is wellness, right? At Highmark, we call it living health, but it is literally making people well. That's a good business strategy in this particular business.
Yeah, we just say use a clinically validated tool for the population age that you're treating. CGI, I think, is not necessarily a patient-reported outcome measure. We see that. So I think it really comes down to really looking at who is the patient population and what's the right tool. I don't think payers should be, I agree, I don't think payers should be dictating what tools.
Do you have any concern about adverse selection of patients with providers?
That's a great question. I worry about that all the time.
It wasn't mine, it was somebody else's.
Great question. And yes, I worry about that all the time, because one of the ways that you want to incentivize measurement-informed care, right? Especially for those practices that say, I can do this better if I get an EHR and I need to invest $1 million to do this. Will you do anything for me if I'm able to do that? And absolutely, we've got to extend our hand and say yes, and help to create a business case for that entity. But the issue of treating you know, in an earlier talk, I talked about the difficulty is if you happen to treat narcissistic personality disorder, right, and you get incentivized based on patient experience, your scores are, you're going to be disadvantaged, right, because narcissists devalue the therapist typically. And another person is treating dependent personality disorder as my expertise. Well, they love their therapists. So if you're incentivizing based on patient experience, you know, you have to think very thoroughly about how to make this fair and equitable, and how to not create a situation where the narcissists don't have any therapists, right? That selection, you know, I'm not going to take this hard patient because it's bad for my family, right? We cannot create those situations. So we have a lot of work to do, but we need to recognize that it is work that must be done and agree and get behind measurement-informed care. And in order to do that, I think that we have to show that we're not going to implement it in a fascist way. Sorry to use the term, politics on the mind here, but you know, you're not going to implement it in an overly rigid way that is out of reach for some network providers.
I think that question falls under whoever asked it, the things that keep me up at night, because there really is a lot of concern that I've had in terms of looking at our severe SPMI population and individuals who are turning or creating models to pivot to that, right? When you look at some of these value-based structures or models and you look at historically, payers have used claims data, right? So you're looking at inpatient admissions, you're looking at ER, you're looking at outpatient utilization in terms of engagement, increasing community tenure, reduction in overdoses, things like that. Those metrics are going to look very different for different populations. And so you need some component of severity adjustment to account for sort of baseline measures for populations. And I think that's why the industry at large, or one of the largest reasons that the industry at large has really struggled with value-based payment arrangements is this: how do we adjust for these subpopulations, right? We just want to treat behavioral health like one big umbrella. But when you're struggling with an individual with substance use disorder, chronic homelessness, et cetera, ERs are going to look a lot different for that than the individual who is functioning, working 40 hours a week, able to maintain a job, has stable housing, et cetera, and is struggling with mild to moderate depression. And so we have to be really careful as payers in terms of setting targets so that we don't set targets that sort of misalign with populations that we really need treatment models for. And we have to have sort of tolerability for chronicity and looking at kind of reduction in baseline for challenging and challenged populations.
Speaking my language. Paul, you look like you had a comment that you wanted to make.
Just very well said. I think, you know, if you address that particular issue around subpopulations that are super sick and you're not going to, you know, either not be able to move the needle much, or you're going to just start at such a low baseline that you may not be able to prove success. In the larger kind of market, I think with like the modal patient who's got moderate depression, anxiety, seeking care, I don't personally feel like the introduction of measurement's going to do much there in a negative way, because the market's already built in an arbitrage around this, which is if you're a handful, the market's not interested in you, and you know you don't get your phone call returned. I mean, it's kind of just how it works. So I think that's I don't see a provider group saying, oh, we're getting measured now, I'm not going to take that really super difficult case, because right now they're not taking the super difficult case in the modal outpatient practice. So I don't think that's going to have a negative effect, but we got to be careful if you're contracting with a big group that has an intercity or Medicaid population, you got to be mindful of that.
We're right about time, but I want to ask the panel one last question, which is our miracle question. 5 years from now, what do you envision? What would you like to see for measurement-informed care that we're not doing now? You've heard some ideas here, but I think it's also valuable to really be able to think
Just,
big.
You know, maybe, if not a guideline, kind of a consensus around what good looks like and what is success, whether that's thresholds or if it's a response remission platform, that could be fine, but just kind of, because it doesn't seem like there's agreement across the board.
You might get your wish a little faster. Someone posted that the NQF has a press release today about trying to standardize measures, so I think there's a news piece for us all to check out afterwards. Liz?
Interesting timing.
Yeah.
So I'll piggyback off of that. I think my miracle would be that we are able to move beyond symptoms as a sort of hallmark for measurement-informed care. I do think we need to look holistically at our member and patient population and be evaluating things like functional status, impairment generally, how they're doing in the community, SDOH factors, et cetera. I think measurement tends to be symptom measurement, and whatever measure that we get to in consensus, I do think it needs to be more intrinsically holistic.
I think my miracle would be really progress, and for me that would be for IBX really an increase in the models that we have out there. We really are committed to looking at the different types of providers, the populations that they're treating, and coming up with programs, agreements that work specifically for that provider. That said, it's an awful lot of work, and customizing those agreements is significant effort, but looking at having kind of a platform to support kind of the providers and ingesting the measurement data for ease of use, and then broadening kind of our model set to account for the difficult to treat populations, the substance use, the SMI population. So really just progress.
And I'll be quick. My hope is that we are talking in 5 years as frequently about measurement-informed prevention as we are measurement-informed care. So that's going to be the next frontier for us. What are you, Joe provider, doing in terms of prevention, and how successful are you at it?
Keeping people well. All right. Thank you to all the panelists. Thank you all for being here, and thank you for using the QR. Those questions were fantastic, so thank you all.